Dear students, we are in the final part of the chapter elbow complex, continuing from the earlier part. So, we have understood that the three qualities of the muscle, such as strength, speed, as well as muscle quality, that is the peak torque per unit of muscle mass, basically is reducing or decreasing more faster in men than the females in aging process. Active flexion bar extension peak torque, that is active flexion, either flexion or extension peak torque power and angle of peak torque production measured bilaterally showed highly significant differences between young and old. So the quality of contraction, that is a peak torque power and angle of peak torque production, when conducted a study and were clearly showing that difference is different from young and old. That means the aging is affecting the muscle power or peak torque. However, no age-related differences were occurred. So all these above changes were more prominent for elbow, flexor and extensor muscle. Supination and pronation, that is supinator and pronator muscles did not show significant deterioration of muscle power due to aging. So injuries which we commonly see is injuries to the elbow are fairly frequent because most of the child in a childhood or in adolescent age, the children, the boys and the girls, they start to play and the contact sports, football, cricket, rugby, or those kind of games, indoor or outdoor, such as kabaddi, or those severe injury is possible. And most of the sites for the strains or inflammation is the apophysis. An understanding of the mechanism of elbow injuries and the relation to the elbow joint structure is necessary for determining the effects of the injuries on the joint function. Because with all the knowledge we have acquired through the when we studied the whole chapter, understanding the articular structure, then the stability factor, how which muscles are there, what is their action, the range of motion, the structure of ligament, what kind of stability do the ligaments and the articular structures provide. This helps us to understand and the mechanism of injury also, and it is helpful for us to in healing those cases also. Compression, now coming to compression injuries, resistance to elbow resistance to longitudinal compressional forces at the elbow is provided for mainly by contact of bony components. Therefore, excessive compression. So we are now when you're discussing the compression for forces is here the force vectors are directed towards each other. So that then there is a compression component coming. So this may result in the failure of the bone. So otherwise called as fractures. So compression fractures may be happening, and also injuries of the soft tissue can also happen, especially the intra-articular structures. Falling on the hand when the elbow is in the closed back extended position may result in a transmission of the forces through the bones of the forearm to the elbow. Usually somebody falls on the floor, outstretching their hand. The force will be transmitted either through the mostly through the radius and sometimes through the ulna also. So either way the force may be transmitted through, sometimes the fracture may happen in the radius, and sometimes the force may transmit to the humerus and the humerus may go for fracture, or sometimes the humerus may also, as in the earlier chapter when we studied in the shoulder complex, even it may transmit and then the fracture may happen in the clavicle also. If the forces are transmitted through the radius, as may happen with the concomitant valgus stress, so we have studied the valgus and varus, gluteus valgus and varus. The stress may, due to this valgus and varus, stress may happen. A fracture of the radial head may result from impact of the radial head on the capitulum. If the force from the fall is transmitted to the ulna, a fracture of either the coronoid or olecranon process may happen and may occur at the impact of the ulna on the humerus, mostly on the trochlea. So here, if the force is transmitted through the radius, the radial head on the capitulum is going to fracture. If it is transmitting through the ulna, coronoid or olecranon process may fracture. If both of them are not fracturing, that means that the force may be transmitted and maybe fracture may happen in humerus, or either the force may be transmitted upward. If neither the radius nor the ulna absorbs the excessive force by fracturing, then the force may be transmitted to the humerus and may result in a fracture of the supracondylar area of the humerus. Muscle contractions also may cause high compression forces at the elbow. So muscle contraction injuries may also happen, and the muscle contraction injuries may lead to nerve compression, bony fracture, or mostly dislocation may result in the due to severe muscle contractions. Repetitive forceful contractions of the flexor carpi ulnaris muscle may compress the ulnar nerve as it passes through the cubital tunnel between the medial epicondyle of the humerus and the olecranon process of the ulna. So, whenever the ulnar nerve is injured due to the compression, severe contraction of the laterally oriented flexor carpi ulnaris muscle inside the tunnel, which is formed by the medial epicondyle of the humerus and the olecranon process of the ulna. This may here it may happen. This ulnar nerve injury may subject to not only here we are talking about compression and also sometimes traction injury or friction stresses due to flexion and extension. Elbow joint is commonly some more mobile joint. Mostly we are always moving the joint. So traction and friction injuries of stresses due to flexion and extension of the elbow may also lead to ulnar nerve injury other than the commonly seen ulnar nerve compression in the medial the tunnel, that is the middle cubital tunnel. So this type of stress injury is called as cubital tunnel syndrome, in which what will happen, the ulnar nerve is affected in the cubital, the supply of all the muscles lower in the lower region will be affected, and the fingers affected are the fourth and the fifth fingers is impaired. Distraction injuries. Now we complete and we discussed about the compression. We coming to the distraction injuries. Ligaments and muscles provide for the resistance of the joints of the elbow complex to longitudinal traction. We have studied this earlier. Which are ligaments? Which ligaments are giving stability? We have studied about the medial collateral, lateral collateral ligament, how they are giving stability along with the muscles of tendons and the muscles of the area. A tensile force of sufficient magnitude exerted on the pronated and extended forearm may cause the radius to be pulled inferiorly out of the annular ligament. This injury is common in young children younger than the 5 years old. 5 years old children may sustain this injury. I'll show you. See students, now here you can, this is otherwise called as pulled elbow. Now you can see this child, somebody is pulling the child, grabbing the hand. So here what is happening is when grabbing through the hand, through the wrist, the person is trying to lift the child. The radius, the proximal head of the radius, that is here, which has to be inside the annular ligament, comes out because of the longitude. Even though we call this, it is moving inferiorly because anatomically it is moving inferiorly, but here in this orientation the injury happens when superiorly the person is pulling it. So the inferior, the radius moving, if the child, after the injury, when the child comes, there is an inferior dislocation of the radial head from the annular ligament. Lifting a small child up into the air by one or both hands, or yanking a child by the one hand, is the usual causative mechanism, and therefore the injury is referred to as either nursemaid's elbow or pulled elbow. Next, in the same distraction and compression, in the valgus and varus injuries, you will have same hand, you will have compression as well as distraction injuries. In the valgus, cubitus valgus, you can see the lateral side goes for compression and the middle side goes for distraction during valgus. Same in the, if it is going in for the varus, cubitus varus, the middle side will go for compression and the lateral side will go for distraction. That distraction means tensile stress is happening. So here you have to understand that whenever wherever there is a outward deviation, there is distraction. Here there is, and here opposite is a compression. So distraction and compression forces are created if either one of the collateral ligament is overstretched or torn. If one side of the joint is subjected to abnormal tensile stresses, the other side is subjected to abnormal compressive forces. One side goes into compression, the other side goes into distraction. Here the one side, the lateral side goes into distraction, the middle side goes into compression. A study in a baseball pitcher means those are bowling in baseball or in cricketing bowlers in cricket or in rugby players throwing the ball. Such kind of players, any they have done a lot of studies and they have found that these players are having full thickness tears of the medial collateral ligament. Mostly half of the players because they are commonly repeating this activity. Other common cause conditions which we see is ulnar neuritis, flexor pronator muscle strain, or tendinitis, flexor and pronator muscle strain. So most of the time they when in pronated position when the flexor elbow flexors are working, that may lead to a strain or tendinitis. And medial epicondylitis, which is also common. And the most common is a tennis elbow, which we are going to discuss. Medial tendinitis or medial epicondylitis may be caused by forceful repetitive contractions of the pronator teres, the flexor carpi radialis, and occasionally the flexor carpi ulnaris. So medial tendinitis or medial epicondylitis means forceful repetitive contraction leading to injury of the pronator teres, the flexor carpi radialis, and occasionally you can add FCU also, that is flexor carpi ulnaris. Now very commonly seen in tennis players, and most of the time the patients who come to us, the ladies also, because of the kitchen or the chores in the kitchen, they have this pain, that is a lateral epicondylitis, commonly called as tennis elbow. Famously our cricketer Sachin Tendulkar had this, and this is a very common for cricketers and tennis players. Mostly it's common for tennis players, also for anyone who uses their extensor here the injury, its wrist extensor has been into repetitive stress, and the wrist extensor repetitive forceful contraction. Main muscle affected is ECRB extensor. Don't forget this, students. ECRB, tennis elbow means ECRB, that is extensor carpi radialis brevis, is a muscle which is affected. Some studies say that EDC, that is extensor digitorum communis, is also affected. Finally, coming to the last part of the final section, fractures of the in the elbow the chapter elbow. A Colles fracture is a type of fracture of the distal forearm in which the broken end of the radius is bent backwards. A Smith fracture is a fracture of the distal radius. It is caused by a direct blow to the dorsal forearm or falling onto flexed wrist, as opposed to the Colles fracture, which occurs as a result of falling into wrist extension. Fracture, that is Colles fracture as well as Smith fracture, are fractures of the lower end of radius. The only difference is Colles fracture, the person tells you a history of falling with the extended hand, means that the person has opened his hand, fell down on the hand with the fingers spread. So what will happen is the radius will break and it will bend backward. So this bending backward in Colles fracture in an outstretched extended hand is due to and is will create a deformity called as bending the dinner fork deformity. The only difference in Smith's fracture and Colles fracture, Smith's fracture is a fracture where the person fell down with a flexed wrist. Here the radiological demonstration is there. Here this is normal, radius is normal, and both in AP view here and posterior. This is a lateral view. Here you can see, and here you can see the fracture. These both are pathological. Bending backward, bending dorsally. The distal part which is fractured, the distal fractured part is bending backward. When you see on the sideways, the person may come to you and not come to you. Usually they go to the surgeon with this, and here the dinner fork deformity you can see bending backward. Smith's fracture is a fracture of the end of the radius. In Smith's fracture, only thing is the history is that they fell down with a flexed wrist. Thank you, students. We have completed the chapter elbow complex. Any feedback, any doubt, please send your feedbacks, and anything to clarify, I will do that. Thank you very much.